patient brings the lenses back for aftercare visit, normally we'll check the condition of the contact lenses. And if there's anything happen, as after 6 months, where the result may not be good compared to the early 3 months ago, then you want to check whether the lens actually has warpage, okay? And also the quality, whether the lab will send you the correct lens by looking at the face curve. Alright. Now, what's the ideal candidates?
How young you visit? How young you visit?
My youngest patient, 5.5 years.
Yeah, it's pretty much the same. We're feeling more younger and younger and younger.
But
5, 6 years old.
To be honest, 5.5 years, some 9 years old cannot accept wearing contact lenses.
Even
some, yeah, even sometimes 70, yeah, even 70 they cannot accept because the eye is so sensitive that they don't allow anything to touch their eyes. Okay, so
especially we have a lot of people not feeling all okay yet. So we probably suggest you don't challenge yourself fitting something really high prescription. And high prescription like a 5 and above with 1.5 or 2 astigmatism as well.
Yeah, out from this range, out from this range.
Okay. Try to do low script with a really good eccentricity first.
Okay. This is a challenging one. Don't touch in the first place.
After how many? 50, 100, 200?
It depends. I got one after 5, 10, then you want to challenge the ones.
You challenge yourself.
Not me. Some practitioners from my hometown. Okay.
It's a Malaysian practice.
No, we are more adventurous.
Okay.
Right? Malaysia, Malaysia. Okay, then those are the challenging candidates. Great.
So finding the right candidate for your first 50 is very important. That's how you're going to build your confidence and also making your patient feel really comfortable with you, and you will have more and more referrals. So don't be too adventurous. Yeah, just good normal, average and normal first.
Pick up the first few patients carefully. Yeah. Those are a no-go, right? Severe dry eye getting more and more prevalent nowadays. Even the young adults, teenagers also facing the dry eye problems. We'll talk about it later. I think Jocelyn is a dry eye expert now. Jocelyn, we can talk about one hour of dry eye. That's quite detailed. No, we're not going to talk about it for this moment. Okay. All right. So we proceed to this one. The feeding procedures.
Now, it's very important. Make sure your day one data need to be recorded carefully and properly. Okay? And one more important thing is the photography, isn't it? Look at the fluorescent pattern.
The fluorescent pattern, yeah. So that's the procedure for a good Ortho K feeding. Alright? You want to fit Ortho K first, take the baseline photography. Then you need to record the flat and the steep K reading, spectacle RF and the eccentricity. And also you have to record down the difference in cornea elevations in micron, record HVID and pupil size.
I think now we not only look at HVID as well,
but
the DVID.
DVID as well.
Because I was in China a few weeks ago, and in the hospital, one of the patients never been fitted right, no matter what they do, increasing toricity, blah, blah, blah. The oil is always going high. Okay, so they asked me how to look. And I look at it, that patient's really interesting. HVID is about 13. 13. It's quite big. Big eye. So they custom a big lens. The lens is always running high. But I look carefully and look at that patient's eye. Actually, the DVID is about 12. So really interesting, like an oval. So end up, we find a trial lenses. We find trial lenses about 11. Put the patients after about 30 minutes. the cornea shape just pulled out straight. So we have to look at the PVID. That's one thing why we are quite stressed in live fitting, trial fitting, and freezing. So we want you to understand the really beauties of corneal relationship with the fluorescent pattern behind.
Correct, yeah.
Once you master this skill, you will be the master in orthokeratology.
Yeah, I learned that from Nick Stoyan, no?
Yeah,
that's right. Yeah. You need to interpret the fluorescent pattern correctly. Yeah. Good. This is a fitting procedure that you need to record.
All machines, all different company machines always give you the data of the flat K, stiff K, electricity. Some company machine even give you HBID, all the information, all the detail. All the machines do the same things, but they just present differently. Like we all speak different language, but when you go to topography, we all speak the same.
Right? Okay, good. So that is the choosing the first trial lens. Now we're talking about fitting method. You can have software, the wave software, and you can have empirical fitting. Now here, me and Oliver are more towards trial fitting. Because trial fitting is so important because it helps you to get the cornea shape and also the fitting relationship and also the post-fit assessments correct before you order the lenses. Right? Now, first you base it on the cornea data. Right? Then you select the trial lens based on the flat K. This is the blue area, the flat K. Then you have to take the E value, look at the E value. Then you choose whether the first piece of trial lens is based on the E value. If the E value is 0.3, then you choose the trial lens at 0.5D than the flat K. In contrast, the E value is more than 0.7, you choose the trial lens as 0.5D flatter than the flat K. Right? Now this is example.
So each company have their own design.
Yeah.
So like Steve already mentioned to us this morning, the lenses can have 0.4, 0.5, 0.6, 0.7. Different company have a different design, the eccentricity.
Yeah. So in this case, Ollie, if you're going to fit the OKE,
the E system
the
is
E system very important. See. So for non-OKE system, you choose 42.25, slightly flatter, because of the higher eccentricity. But for the OKE, you can choose 42.5 with E 0.6.
Some company they might use to take the average K. Okay, they don't some average K, some companies don't care about the eccentricity because you can have some designs for spherical design, some spherical design. So we have to familiarize, understand the system you are using.
Follow the guidelines.
From
the manufacturers.
Okay. So you have to remember, A design is different to B is different to C.
I think later we will discuss about this OKB. This is a general. Okay?
This is general. So always refer to the manufacturer guideline.
Okay, now, step by step, I have a patient with this RX. Okay, this is a K reading here, E value, HVID 11.9. So next, I'm going to look at the elevations difference. Where's the elevation difference? Now, the set difference at 8 mm fault. Actually, the Metron can automatically tell you the amount. And this is the old version. No, it's the old version. You can do it from here, or alternatively, you can do it here manually. Sometimes you need to do it manually because why?
The eye is too small.
Yeah.
The eye too small. So make sure TC said when we pull up and pull down, you try to get the machines measure the most extreme.
Yeah.
Okay? Asian eyes always is hard.
Yeah. And plus, the method also will tell you the average steeper, the difference in
South to
elevations.
north, south to north,
Yeah.
east to west.
This is a flatter zone. So they take the average. In reality, what you want to go deep into the analysis, you know that you look at here. You measure the elevations at this point. Point is 4 millimeters from the center. 4 and 4 is totally 8. It's 8 millimeter chords. Now for those beginners, we need to explain the chords, the chord length. But if you use a normal design, the chord length is always 8 millimeters. But some manufacturers do have a different chord length. So you have to refer to the manufacturer, then you put it here. In here we generalize it using 8 millimeter chord. And therefore you can see here the elevation point is minus 13 micron versus 27. You will know that the cornea is steeper at bottom. Versus 2 is 2 and 3. This is quite even, right? Okay? It's quite even. Now, when you calculate the sagittal height difference or elevation difference, you take this 2 plus, take the average of the north-south and the average of the east-west. Then you have, excuse me,
23.
Yeah.
23.
It's 23.
So some design, they can tolerate 23 micron for spherical. Some company, they cannot tolerate. Once you're over 20, you need to use toric.
Yeah.
So
it depends on the
design. It depends on the
Depends
design.
on
Yeah, it depends on the design guideline.
In this case, I use spherical for my patients. Right? So the first trial lens used, I got trial lens sets. Okay, the trial lens set. Pick one trial lens which the closest to the flat case. And this is the one that I picked. Then I put it on. Now, Ollie, you like it?
No.
Why?
Probably can be a bit larger.
Yeah?
Yeah.
Yeah, this is trial lens. It's like
The trial lens is good.
Yeah, trial lens. It's trial lens, Yeah.
Now, when we do orthokeratology, it's different to when we do RGP. Ortho K, we always start from this outside. So size is very important. Okay? That's why size is very important. We have to get lens size right. Then going from outside to inside. Okay?
So when you first interpret fluorescein pattern, the first thing you look at is which part?
Which part?
Yeah.
When I look at the fluorescein pattern, the first thing I look at the center part first.
The central part.
Have a look at it.
Okay.
It's already determined, telling us whether the lens is actually rematching, pushing down or folding.
Yeah. Actually, different practitioner, different preference.
What about you?
I like to look at the overall first.
Which part? Nothing called overall.
I can have overall.
You too greedy. No.
Well,
But you're adventurous.
yes, as always say, okay, as always say, you look at
You put
the center.
center. You pick must be center.
Yeah, the center is very centration is important. Yeah. Now, always say you look at the central bearing. This is called central bearing. Central bearing must be 3 or 4 millimeter wide, right? And then you look at the tear reservoir now.
Which is the reverse.
The reverse zones.
That's what we call the magic zone.
Yeah. So reverse zone, the tear reservoir band must be 1 to 1.5 millimeter wide, and it's going to be even. more or less even, right?
This is more like a standard design. Okay, when we're going to look at myopia control design will be
Really
really
different, yeah.
very different.
This afternoon we'll show you that. Now we can discuss more about it. And then look at learning.
Alignment.
Alignment zone. This is alignment zone. Now, the crucial part is whether you have to notice whether there is any fluorescein leakage.
We want to have like a 360-degree seal.
Seal off.
So, I think remember when we have the seasonal storm, like Philippines have a really bad storm and the storm before about a month ago. So think about when the area a bit lower, waters always go. Correct, isn't it? When there's some leakage of fluid, the lens will move to that area. Okay? That's why TC always teasing me, I got a lot of money. Because Australia is lower, so all your money will go down to Australia. Oh, and Dubai's got more. We bought oil.
Oh yeah, that's what even better.
Oil's underneath all the money.
Okay, then you look at the HD. HD, more or less a 0.5 meter wide.
It can't be too tight. If too tight, like Steve mentioned one of the speak this morning, is the lens too tight, it's binding. It's not healthy.
Yeah.
Like you're squeezing someone's leg, you can't breathe. Okay.
Movements, as a 1 to 1.
But this is a general reference guideline to you. And there's some design, basically the lens is really tight, right? There's some design of the design of more tight design than loose design.
Yeah.
Okay? And the one we're using for most of the lenses available in the market are spherical design, not the aspheric design.
Yeah.
So spherical design, they tends a little bit tighter compared to the aspherical. Okay, they have the pros and cons, so we can go for this later.
Right. Okay, the other thing is important point. Okay, now. Right. Now, some of you might have seen this, huh? Keep quiet, okay? I want to ask a question. Okay. Is it a good fit, right? It's a pretty good fit, right? If all the textbook perfect features of a good fitted lenses.
So size is good.
Size is good. Central bearing, 3.54 millimeters. Here is lower bearing about 1.5. Okay? Oops. What about this one? Is it a good fit?
What do you notice?
Oh, Steve. Yeah, you see it. Yeah, look at that. Yeah, oh, wow, too steep.
We look at the edge. This is too steep.
But let me tell you, now some of you might know. I showed it in my previous workshop. It's the same lens, same cornea, same eyes. Two different fluorescent patterns. Why?
After TC has...
No, after I've taken this video, I said, wow, good fit. Suddenly, patients here. Excessive lacrimation causing the whole thing to be haywire. So if the point is, you have to let the contact lens settle down, then you interpret the fluorescent pattern, evaluate it. Otherwise, if the patients keep tearing, so excessive tearing might going to affect your judgment.
So,
Evaluation.
so TC and we always encourage everyone, the amount of fluorescein you put in the eye, try to be more consistent for your every single patient. Number two is, after you put the fluorescein, how long do you wait before you assess? Try to have a consistent pattern. Okay, so in the future, you know how you assess the lenses is really consistent. Like 1 shake, 2 shake, or no shake,
No shake.
2 shake.
Yeah, that's a bit of we can agree on that. But one thing that we may not agree is whether we want to insert. Yeah, no. Anesthetic.
Do you
use anesthetic, Josh? Yes.
Do you use it?
Anesthetic for 12 minutes. Yes.
You?
Yes.
No.
No, yes, sir. And so we cannot
Why?
agree.
Why you don't like it?
Save time. Yes, save time. Now, because by you put an instant anesthetic, then you may cause the cornea epithelium is more susceptible to this thing. There might be some research says. But as for me, we want to save time. And some more we put anesthetic, the patient says, it's not too bad, not too bad.
In Australia,
Australia
life is easy.
Yeah, that's right. You
You would let the kids cry for 20 minutes.
Stops the tearing. That's the thing.
Yes, it stops the cheering. That's what the anesthetic, we have anesthetic on, yeah.
We do differently.
Yeah, that's right. But anyway, whether you want to instill anesthetic or not, bottom line is you need to allow enough time for the tear to settle down, for contact anesthetic. Okay?
How long? Normally,
If anesthetic, then I can 10, 15 minutes. Okay? But I have some patients who are never going to settle down. Keep tearing, whatever, how many anesthetic drops you put, still you keep.
did you put the wrong one?
No?
My trick is
Hey.
most of my Ortho K kids who come, okay, after you put the lens in, after 5 minutes, and I say, hey, it's to TC, eh? Now, here's the voucher, go up front the corner, the snowman without a leg.
The mission.
The bubble tea. I give them the voucher, they go to have a bubble tea, they forget everything. So 20 minutes come back.
That's a trick, eh? No, the mission is a very cheap, no?
You know the mission is
You know mission, yeah, that's right, yeah.
But it's just a bubble tea, the kids are bubble tea.
Something, okay. You put something, you know. Is it what you do? Put something about the thing.
That's what the kids will forget. So
Okay, serious. Okay, serious.
not serious, it's true.
Now,
So that's how you make the kids forget about the pain. They will always remember your sweetness.
Now, what if you have a patient who keeps tearing with very sensitive eyes,
Come back.
and then you cannot assess the fluorescein pattern? I have that patient as well. So what do you do? Normally, you forget about fluorescein evaluation.
Forget about it.
Yeah, forget about it. And based on our judgment, you give the patient the best trial set. Okay? 10. Go back and run for 2 nights. Or 1 night. Overnight trial is essential. We are from the old school, you know, remember last time?
John Manfred
Yeah,
always
John
come back
Manfred always come back in the morning, yeah, after one overnight rain, and evaluate the fluorescent, not fluorescent pattern, but the corneal topography. Corneal topography. See whether you got bruised eyes, central islands, or smiley face. We do this, okay? So that's protocol perform over refraction with your tolerance on. In this case, the over refraction is minus 425. Then you have to teach the patients to insert, how to remove the lenses correctly, how to bring the lenses correctly, and schedule to come back for post-trial wear assessment in the morning. I know sometimes it's very essential, but nowadays you can allow patients to wear the lenses for half an hour. Then basically you just ask the patient to close their eye, pretend that they're sleeping. Then half an hour later, you remove the lenses to see the post-wear result. Then from there you can confidently tell whether you want to proceed for another trial or you go for to proceed and order lenses. Right? Okay, good. Right. What is the possible outcome for the post-wear assessment? Post-wear topography course. 6 possible outcomes. Okay? The bullseye, smiling face, central island, false central island, crony face, lateral decentration. Let's do one by one. Now, if you follow the guidelines from the manufacturers, I would say 70 to 80% of chances that you will get everything correct. You get a bullseye method. Okay?
If the map is right.
If the map is right, yeah. This is the bullseye pattern overnight. Yeah, this patient wore out the lenses overnight, and you can see this diagram here is axial map, axial difference. See, axial difference map. That one is the tangential difference map.
So axial is telling you what's happening to the cornea, the refractive changes, and axial is tangential telling us where the lens was last night.
The central, whether the lens
Two different story, but same lens.
Yeah.
Give it two different.
So from here, you will now, this is the bullseye pattern, but it's incomplete bullseye because the patient only wore the lens for one night. Okay? But more importantly, if you get the incomplete bullseye, doesn't matter. As long as the cornea is clear, no staining, then you proceed to look at the centration of the lens. The tangential ring, the gold-up rings here, sit centrally, then you know that the lens is good. Sit centrally, then you can proceed and order the lens. Okay? So, remember the overall refraction is minus 425. The trial lens set that I use is minus 4. Okay? So the lens order is 42.25, 11.2. Why 11.2? Because it's a big cornea, so I increase the total lens diameter and achieve this. So I keep the alignment curve, the reverse curve, and basically the same as the trial lens.
So for the size, you judge by your eyes, or judge by 90%.
Okay, the guidelines say the diameter of the lenses must cover 90 to 95% of the cornea diameter.
So
This is only guideline.
The hardest part is for us to measure the HDI. So the best is put the trial lens on, look at it, you see the limbus, and then you know how much you're going to make it bigger or make it smaller.
Don't make it too small or too big. Just right. Middle pass. Yeah, middle pass. Okay? Now, you order the lenses arrive, you check everything, lenses is good, then you ask the patient to come and collect the lenses. Then you do the dispensing. What is the procedure that you normally do? Again, I'm the old school. Again, John Marford, sortless or mixed. Sortless that check with the lenses on, you check the VA. The VA must be 20/20, and you perform the Rossi evaluation. See whether the lenses fit correctly, the lens comes to the parameters that you want, and teach the patient how to put the lenses in both the lenses. And also the maintenance